Welcome to Bridging HIV and Substance Use Disorder Innovations in the Field. So the National Alliance for HIV Education and Workforce Development, or NAHU, is a membership organization of the 8 regional and 2 national AIDS Education and Training Centers, or AETCs. It was established in 2010, and NAHU supports the AETCs, a component of the HRSA-funded Ryan White HIV/AIDS program, which have an explicit directive to build and maintain a well-educated and culturally sensitive health professional workforce that can provide prevention, diagnosis, care, and treatment and medical management for people at risk for and living with HIV. NAHU collaborates with multiple organizations in order to promote and educate on the work of the AETC program. Since 2018, NAHU has been funded by the American Academy of Addiction Psychiatry as a partner organization of the Opioid Response Network to address the intersection of HIV and opioid use disorder. ORN was created to support efforts in addressing the prevention, treatment, and recovery of opioid use disorder. And ORN provides free resources and technical assistance locally in communities across the US and its territories. So please visit the ORN website for more information, and you can also submit a request for technical assistance there. Today's program will also have accreditation. There will be a post-evaluation survey that will be sent to you. We will also have a link in the chat towards the end of the session. As always, it is your own responsibility to make sure that you are verifying your requirements of your state licensing board, but we will be sending out the certificates after 2 weeks after you complete your evaluation. So without further ado, we can move on to our main topic today. Let me stop sharing here and I'll introduce our guest speakers. So we have 2 guest speakers today. Colleagues of ours from the AETC world. We have Carolyn Chu, who is a family physician and HIV specialist who completed her family medicine residency and clinical research fellowship at Albert Einstein College of Medicine and Montefiore Medical Center in the Bronx, New York. Prior to joining the National Clinical Consultation Center, she also served as medical director for a network of federally qualified health centers in New York and also helped support their primary care integrated HIV service programs. Dr. Chu currently supports HIV training and education and care delivery at the San Francisco General Hospital's Family Health Center. So welcome, Dr. Chu. And we also have Dr. John Nelson, who has a PhD and is an advanced practice nurse. He is the director of the AIDS Education and Training Center National Coordinating Resource Center at the Rutgers School of Nursing FXB Center. And prior to his current work, Dr. Nelson provided HIV care to adolescents and young adults for 24 years. So I'm going to turn it over to you, I think, John, right?
Perfect. Thank you, Daria. And thank you all for joining us today. I'm going to start by giving a bit of general information and then specifically about the National Coordinating Resource Center and a couple of tools that we have developed with all of our AETC program members for use in providing care to persons with substance use disorders within HIV care services. But it could be used in any care services. So next slide, please. Both Dr. Chu and myself have no disclosures to make around funding or conflicts of interest. Next slide, please. And both of our programs, the AETC National Coordinating Resource Center, which I'm from, and the National Clinician Consultation Center that Dr. Chu is from, are both supported by HRSA. We are 100% grant funded for this work. objectives. We want to review how newly curated AETC program care toolkits were designed to assist clinical teams integrate behavioral health and substance use disorder SUD services into a wide variety of practice settings, and to identify opportunities where the National Clinician Consultation Center's warm line services could help bridge the gap to increase access to treatment and improve health outcomes of clients. Next slide, please. Okay, so the NCRC, or our abbreviation for the National Coordinating Resource Center, has 5 main responsibilities. The first one is that we serve as a repository on our website, which is AETC for educationtrainingcenter.org. And there are a ton of resources available to you, including links to the AETC program National HIV Curriculum and an HIV HCV co-infection curriculum, as well as calendar events for all 8 of the regional AETCs, and social media connection, so you can connect to our social media through also and follow them for updates on new trainings or upcoming conferences or new resources, as well as we have a blog. We have blogs that are written, and we have a directory of all the AETC programs. So you can look up where your regional AETC is if you need training, or you can identify any of the warm line numbers for the CCC, the Clinician Consultation Center. And we also have an app, which is also provides you with many of the same features. It provides some basic guidelines on treatment of HIV and PrEP and rapid ART, but also provides a directory of all of the regional AETCs and their local partners, as well as the 2 national centers. Next slide, please. Second is that we organize and facilitate national communities of practice, which include AETC program members that are experts or well-versed in whatever that discussion group is taking on. So currently we have a HIV comorbidity group, a practice transformation group, and an in the HIV epidemic group. The tools that we're going to discuss in a moment were created over the last 2 years by the HIV comorbidity group. And that was because mental health, behavioral health issues, which combines mental health and substance use disorders, are a leading cause of morbidity within our populations of persons with HIV. So we wanted to help to, and added to that, COVID has increased the need for mental health services and support. So we created tools that would hopefully allow care providers to be able to increase their responses to the needs of behavioral health and substance use disorder needs of their clients. Another couple of factors that we do are the NCRC is responsible for marketing and promoting the AETC program, and we organize and facilitate the annual Ryan White HIV/AIDS program clinical conference. So this is for primarily prescribers who provide care in a Ryan White HIV/AIDS program funded clinic from across the country and the US territories. And it could be for parts A, B, C, D, or F, and is held annually. Our next conference is coming up in October, and will be in San Diego. Next slide, please. Okay, so why this why did I already spoke a little bit about why we developed these two tools. Each year, this group, the HIV comorbidity group, decides what topic aren't there a lot of resources for, and what should we try to find or develop or implement or augment to help clinical teams improve patient care outcomes. So depression, anxiety, and substance use disorders occur significantly more frequently among people with HIV than among people without HIV. Also, people with HIV with a behavioral health disorder are significantly more likely to drop out of their HIV care if compared to a person with HIV without a behavioral health disorder. And we also know that then also links to viral suppression. So those with who drop out of care are therefore significantly more likely to not be virally suppressed, and that is worrisome for their own sake, as we know that having an undetectable viral load is really the best option for maintaining a healthy body as much as possible, but we don't want to forget about the mind. So persons with HIV and a behavioral health disorder are significantly more likely to remain in HIV care if they're receiving adequate mental health services. And that's the important saving grace of this, is that we know that with the right support, that people have a comorbidity of behavioral health, whether that's substance use disorder or a depressive disorder or mood disorder, are more likely to stay in care and be virally suppressed, as well as be able to live a quality life with care of their behavioral health disorder as well. Next slide, please. So despite the high need of behavioral health services, the levels of screening, diagnosis, and linkage to services engagement and therapy, psychotherapy and or medication-assisted treatment are lower. So the need is high, but the services, as we know, are low. And that's throughout the United States, whether you're in a metropolitan area or a rural area. Stigma plays a huge role in this, internalized and externalized stigma, and that also disrupts the accession of needed services, as well as letting the therapy team know that you need to make changes in your treatment plan or in the ongoing expectations. Clinical care teams can reduce stigma by making behavioral health screening, diagnosis, treatment, and follow-up a routine part of the care of all individuals, not just designating people who are acting like they have a disorder, but everybody. We all have mental health issues, and with the right support, all of us can maintain our stability and keep functioning, but some need more support or different types of support, and we'll get to that in a minute. Making a clinic a welcoming space for people with behavioral health concerns or needs is essential, while providing a united clinical team. So it takes the whole team to work collaboratively in routine behavioral health screening, diagnosis, treatment, and follow-up. Okay, next slide, please. So we created this tool 2 years ago, integrating behavioral health into primary HIV care, covering the bases. And what this does is kind of go through the different steps of the behavioral health care continuum, from diagnosis to recommended treatment to engagement and maintaining treatment in mental health services, as well as the outcomes. Looking at, is this effective? Is this working? Are you feeling better? Do you feel safer? Do you feel more in control? Whatever the issues are. And so this has to be done along with when working with people with other comorbidities such as HIV or diabetes or any other chronic illness. So this tool, which you can get on our website for free, and we can go to the next slide. And the thing we start off with is kind of some basic overall operational considerations. One is it needs to be a clinic-wide messaging. So everybody's got to be on board. It's just not the nurse practitioner and the physician. It's got to be from the front desk to the security guard to anybody that a client may encounter in coming into the clinic. And it's important for it to now be responsive to the needs both in person as well as through telehealth, telemedicine, since many clinics are now offering that in addition to in-person care since COVID. So for non-acute care visits, a screening process is in place for routine. Again, this is routine. It's not a once a year checkoff. It's a routine part. So we're normalizing the need to be checked on where we are at this moment on mental health issues. Make sure that we're okay. And or do we need some more support or help? And that it's important to know that when you're normalizing it, not every clinic visit do you need to do that. Like a lab visit only, you don't necessarily want to open up the jar if there aren't the providers and the team members available to help get you to the next step. This is a step-by-step model, and so we want to make sure that there is minimal gaps between the steps. So you don't want to say, you don't want to screen somebody, do a depression inventory and find out that they are more than likely to be severely depressed and then not be able to help them to the next step at that time. And so many occasions there's an annual depression screening and it gets done by the patient in the waiting room. It gets scanned or put into the clinic, into the medical record, but nobody really follows up on it. Or they say, okay, here's an appointment to see the psychologist, but the patient doesn't show and there's no follow-up after that. So we really want to get rid of those interruptions in the process and really make it patient-centered and help them as much as we can in meeting those goals. Because as you probably all know, having a behavioral health disorder is very emotionally overwhelming, and it tires you out, and it's not just an easy thing to add another appointment to your daily activities. So for acute care and non-acute care visits, we want identifiable behavioral health concerns. So somebody who comes into the waiting room, and I have experienced this more than once with mania, for example, or with some traits of paranoia, not wanting to come into the waiting room. And, I've had to meet clients outside and then walk them in and take them right to the back and then have them registered through me versus standing at the registration desk. So all of these are important things to consider. And who are the team members that are going to help do that and have it all into place? For each step, there's a designated clinical team member that serves as a facilitator to make sure the next step is taken. So throughout this process, there's a closed loop of communication. Communication is essential, as we know. So we need to have a system set up so that we can follow each client and make sure that their needs are being met on a continual basis, not just at the screening and then it's over. Next slide, please. So the first, and I'm not going to read through all these, but the first is the clinic entry. So do the clients feel safe? And do they feel safe letting you know that they are, hearing voices, or that they are, they don't trust the medications. They don't, they're not going to take their medications because they they believe they're poison, and that's not necessarily mental illness, but in some mental illness, it can be with paranoia. So all of these things are, what are we doing in the clinic to make it be a safe place? So, for example, at the very last one, there's a 1 in 4 info, 1 in 4 persons in the United States with mental health disorder, and some safe messaging to put like on there on posters and waiting rooms to let it be known that we all have mental health needs throughout our life. And this is a normal part of being a human being, but that it's not anything to be shameful of or be afraid of, but we're here to help you in that process at any time. Okay, so again, the message has to be consistent throughout the clinic. So, we don't want to say, well, wait until you see the doctor to tell them that, because they may feel safer talking to you as the nurse taking the vital signs than they do to the physician. So it's a process that everybody's got to be on board with and kind of know how to connect the person, how to take them to the next step and prevent them from falling through the cracks. Next slide, please. So the telehealth visits, I want to just say quickly about this is the communication. Is you need to make sure that it's secure and you have backup support if something goes haywire, and both on your end as well as on the patient's end, and being able to access and feeling comfortable accessing it through telecommunication. The other is the safety and the confidentiality issue. And both the client, it's fair to the client to know that you're the only one in the exam room when you're talking to them, or there's 2 people, the nurse practitioner and the social worker. So they clearly know there's nobody else there. The door is closed. It's safe and for them to disclose, knowing who's there. Similarly for them, are they alone? Are they in a safe place where they can openly talk? And that may affect what they say if they are not. And so you want to try to help make sure they get to a place where they are safe and able to talk more freely with you. And that is important also for responding if you're doing a telehealth visit and you have a patient who has a plan and is reporting being acutely suicidal, knowing their location, knowing being able to get them assistance immediately, or if less seriously, if there's a internet crash or something and you're talking with them and you both get cut off, how can you can you call them on their cell phone number, or can they call you on a cell phone number? So all of these things are important to kind of set up and know between the provider or the clinical team members that are engaging with the client through telehealth. Next slide, please. Okay, then there's the screening process. Now on our national HIV, the AETC program, National HIV Curriculum, which is at the University of Washington, and they have screening tools. These same screening tools are also available on the HIV Care Tools app that I mentioned, the AETC program app. And these are validated for most populations of adolescents and adults in the United States. And so you want to make sure you're using a reliable, valid instrument to routinely screen individuals, but you all decide that in your clinic based on your population and the needs in your community. So when you're screening, though, you want to make sure that you respond to those that screen at risk, and or that there's feedback of how they scored, and if you as a clinical team have any worries or concerns, and how to help them, support them, even if they don't score as being severely depressed. What are you doing to help keep yourself from not being so depressed in this day and age, as you know, is very difficult to do. So these are all steps that help you. And on the right, I didn't mention this before, you assign for your clinic, you decide who's going to be responsible for this. Who's going to be overseeing this? Who's going to look at it over time and see, are we using the right instrument? Or so each of these can be different people on the clinical team. And you want to involve as many people as possible who are there on a regular basis, and to have a backup person if possible. I know not every clinic has a lot of clinical team members. Next slide, please. Behavioral health diagnosis and treatment plan. This gets, many clinics are only able to do the screening and the referral, and this is fine. You can use this to help go through that process, whether you're doing it on site or whether you're referring to behavioral health specialists outside of your clinic setting. And this is important. So again, having somebody who is, is familiar with behavioral health diagnosing and treatment plans is very important. Again, it doesn't necessarily have to be a mental health expert in and of themselves, but it could be a nurse practitioner or a physician who has done a lot of this work and is familiar with the recommended treatments and guidelines. So, and included in this is having the client do an individualized crisis plan with the client. So it kind of helps them step by step. If this happens, this is what we'll do. If this happens, this is what we can do. So working through that together. So this is what we're trying to help you with: depression or anxiety disorder, or opioid use disorder, or methamphetamine use disorder, whatever it is. This is going to be our plan. Okay, next slide, please. Okay, and then evaluating, is this working? Is the patient able to connect with whomever they've been asked to connect with, whether it's outside or within the clinic setting? And how are we progressing in the treatment plan? Are there any barriers or things we need to reevaluate or redo? Next. And then for referring off, it's essential that the clinic have a good relationship with whomever they're referring. So you want to make sure that there's what we call a warm handoff. And this is having good communication to be able to follow up with them. And I know this requires consents for you to communicate about the mental health issues, in particular about a particular client. But all of this needs to be in place if you are making referrals. Just saying, here's the name of a psychiatrist and this is their phone number, call them, is more than often not that helpful and usually doesn't get completed. Next slide, please. Okay, so what we've wrapped it up, the tool, with saying these are the key success ingredients: warm, welcoming environment and atmosphere. Is this a safe place to disclose that I'm thinking of hurting myself or that I'm sad every single day? Routine behavioral health screening, again, routine, not just once a year or, if somebody is symptomatic. Everyone knows their roles and responsibilities, clear, timely documentation, and communication, structures in place for routinized communication, and structures in place for warm handoffs between the clinical team members and external providers. Next slide, please. So this is what's called the Optimal Mixed Services Pyramid Framework from the World Health Organization. And what it pretty much says is that mental health is a main issue for everybody. And normally we're able to do self-care. And we all do this. We all, I'm taking a day just for myself. I'm going for a walk, or I'm going to whatever, to do some meditation or yoga or whatever it is. That's our self-care for mental health. And we all need that. Now, when you have an underlying mental health disorder, it can be exacerbated and become more intense in terms of the feelings the individual is having, and that will usually require more support as you go up the pyramid. And the more support you need is also more expensive. So again, by reinforcing that mental health is an issue that everybody has, and we all need these, whether we have schizophrenia or whether we're just a little sad because, you know, the rates of COVID are increasing. We all need self-care and informal community care. So those are the basic management tools that are used. But as we go up, we may need to see a social worker, a psychologist, a psychiatrist. We may need inpatient care for a little while. And all of that's okay. But then we're going to get you back down to where it's self-care and informal community care. Next slide, please. And I know you're probably all wondering, where is substance use disorder in all this? Substance use disorder is in that first tool that I just talked about. This second tool we just created this past year, and it uses a lot of the same commonalities of, is everybody on board? Again, it can't be just one provider. Even if there's one provider doing like a medication assisted treatment, that's great. But everybody's got to be aware and trying to decrease the stigma around accessing care for substance use disorders and behavioral health issues. Who's on first? So who's doing what? How are we going to get reimbursed for doing more of this care? And there are different grants and there's different opportunities for doing that. And what do we have to offer? So if you're just doing an excellent screening and you're getting people connected to somebody outside of your clinic, that's fabulous. That's great. Figure out what you have. What are your clinic strengths and what can we add? Maybe we can do some more harm reduction education. So there's different tools that we link to on this from that concept. And then who should we connect to? And that again is essential to connect to psychiatric emergency departments or general emergency rooms and rural clinics that may not have a psychiatric separate component. Really getting to know whom you can call on when you need them, and to have a good relationship so that there's a warmer handoff when and if you do need them. Next slide, please. And these are resources. This is so small, I apologize. I didn't know it would come out this small. But if you go to the link, you can definitely read these, print them out, and then you can't print, but if online, you can definitely link. These are all hyperlinked to these resources. So I think I'm over. I'm going to shut up and thank you very much. And now I'm going to turn it over to Dr. Chu.
Great. Thank you so much, John. I'm really happy to be able to co-present with you. And thank you everyone for being here, especially on a Friday. I am really enjoying how experienced everyone seems to be and really placed at that intersection of HIV and substance use and mental health. So just really appreciate the opportunity to be with you all. So I'm part two along the theme of resources the AETC program is able to offer providers across the US. We just thought it might be nice to sort of share a little bit of information about the NCCC, or National Clinician Consultation Center. So like John and the NCRC, we are one of the national components of the AETC program. I'm going to go ahead and drop our website information in the chat for those of you who might not have heard about us. But I'll just go over a little bit of history and then really sort of walk through conceptually how a lot of probably what we've learned in the HIV care world as far as treatment gaps and care gaps could actually be applied and may help us sort of reframe our thinking about providing substance use disorder care. Next slide, please. So I'm not going to read all of this, but this is just a little brief background about our history. We've been up and running for 30 years. I am speaking to you from our Family Health Center at San Francisco General Hospital. That is where our program offices are located. Our team is remote at this time, but we continue to field calls from across the US, across multiple consultation lines. Actually, at this point, I think we've got 6 or 7. And as you can see there, given our longevity, we're probably over 315,000 consultations and counting at this point. This was the number that I got when we sent in our slides a couple months ago. I'm really thrilled and sort of, I think one of the unique aspects of our program is that we are staffed by a multi-professional team of clinical subject matter experts. So we've got physicians like myself with a really strong primary care background. We've got advanced practice nurses, and we also have clinical pharmacists who are very experienced in HIV, hepatitis C, and substance use disorder. And I think we really did try to mirror that based on how we know that care teams are being assembled across the US. Team-based care really can work quite well, and we hold true to that with our own work internally, and so we've staffed up in a way that mirrors, I think, what's happening in many of your clinics in the various communities across the US. Next slide, please. So I just thought it might be nice to sort of see a mashup of faces of who you might speak with if you were to call our program. These pics are a little bit out of date. We actually welcomed a new clinical director, Chris Bositis, last year, so I need to update this. But our substance use warm line was actually launched in 2015 there through funding from HRSA to really augment what we were already doing with our HIV teleconsultation and Hep C consultation. So all of you are very familiar with the fact that there are a lot of intersections and overlapping questions and considerations. And so it really made sense for us to be able to augment our operational infrastructure to take questions specific to substance use disorder management as well. Next slide. Great. So I was asked to really provide a little bit of information on how the NCCC specifically can help to sort of bridge this gap, right, in substance use disorder care. And so I thought I could do that by just sort of showcasing a few examples of calls that we've gotten, and certainly we'll have time for questions at the end if any of what I share might be inspiring you to ask questions or just think about how you could apply or use us to support your work. Next slide. Probably no surprise, but I thought it would be good before I go into cases to just sort of reflect on where we are. So we know that many people have a high level of unmet need when it comes to substance use disorder care. And this is really occurring across the country, no matter where you are, but certainly given sort of differing resources and capacity, it looks a little bit different in every community. But I would say there is no single community that hasn't been impacted by this. And I think we all know that. Next slide. So many of you who've been working in the HIV field are probably quite familiar with the HIV care cascade. So I actually thought it was really interesting when I came upon this review that written by folks who are working more closely in the substance use disorder space, and I thought it actually makes a lot of sense that they would sort of pull this over to be able to help generate some conversation. So we know that the HIV care cascade is sort of this public health framework. It certainly does have limitations, but in terms of sort of visually laying out where we could offer interventions, I think it can be a helpful framework to sort of hold on to conceptually. So the areas of the SUD care cascade that I thought I would sort of highlight how the NCCC sort of fits into that role are really from after someone has established a diagnosis of substance use disorder, and then sort of working with clients and patients to sort of get them sort of moved along the care cascade if that's what they want. And we know that this is not linear for many people. Sometimes folks are sort of in one area for a little while, sometimes they move forward and then step back. And that's fine. I think we are all aware, many of us who've been working with people living with HIV for a while know that things change over time, and that's just part of life. Go ahead to the next slide, please. So in terms of linkage to care, I just thought this case that we received sort of nicely illustrated the importance of linkage. So this was a call that we got from a provider who was working in the the inpatient setting. It was a sort of small community-based hospital. And this was a gentleman who had been admitted after an intentional overdose. And as you can see there, the person had been taking sort of street-obtained methadone and oxycodone for a while. And then he came in actually quite sick, and it was sort of unclear whether perhaps he had fallen and been on the ground for so long, but he had multiple medical issues that the inpatient team was trying to sort out and stabilize. When the team was able to get a little bit more of a history, it turned out the patient had been experiencing chronic pain for quite some time. And so sort of like found themselves on this trajectory that many of you might be aware of: chronic pain, chronic opioid therapy, provider hesitancy about continuing it, and then sort of was than obtaining non-prescribed opioids from just other sources. Next slide. So when we got this call, we really encouraged the provider to kind of just step back. Yes, this person had chronic pain, but then it was really important to try and assess whether there was also a co-occurring opioid disorder. And if there was, that really helps to crystallize the sort of treatment pathways. And so on the previous slide, I had just shown a really brief screenshot of the DSM criteria for opioid use disorder, which many of you may be already very, very familiar with. But I just think it's a really important thing to always keep in mind, especially if you are caring for people with chronic pain who may have been receiving chronic opioids for a while, that if you are concerned that there may be problematic use, it is always worth just doing a walkthrough to sort of assess and make sure that you have a really solid understanding of what is going on. Next slide. So some of you may be wondering sort of, okay, well, you guys got the call. What did your consultant say? And basically we asked the caller to just try and get a little bit more history. The person was stabilized and then patient setting. There was a little bit of time to go back to the patient and try and really understand some of the sort of longitudinal pieces that sometimes don't always get unearthed, right, in an acute care situation. So we encouraged the caller to just try and understand, sort of how long the opioids had been used, how much the person was taking, just to try and get a sense of what their tolerance might be. And again, just really encourage them to sort of walk back through the DSM criteria to see if the person had a use disorder or not. Our team, if a caller is willing to provide their email, our team is always happy to send out references after the fact. And so this caller actually really wanted a copy of that DSM to keep on hand. And so we were happy to be able to send that over. And as it turns out, this patient did have an opioid use disorder and they were interested in buprenorphine. So some of you may already know that buprenorphine is fantastic. It can be very effective for treating OUD, and it can also be quite effective for pain. And the other really nice thing about buprenorphine is that it can be prescribed by any provider who has an X waiver. And so there is just sort of not the same level of kind of regulations as might be the case for someone who's receiving methadone via an opioid treatment program. All right, next slide. So linkage to care. So we know that transitions of care, for people coming out of the hospital are really a key moment in time, because we always want to make sure patients are linked to a community provider to be able to follow up on anything that occurred during the hospitalization. And specifically for substance use disorder, if you're starting someone on buprenorphine in the hospital for opioid use, you always want to make sure that they can have a continuity buprenorphine prescriber after discharge. So this slide just sort of highlights those kind of clinical pearls to keep in mind. I don't know if anyone here, works in multiple types of care settings, if you do, a mix of outpatient and inpatient. But if you do, you play such a critical role in making sure that patients are able to get effectively linked to care. Next slide. This, I just thought it might be nice to share. Folks might have heard about the Never Use Alone line, but this is a patient-facing line. I think it's really important to always be able to integrate sort of harm reduction into some of our counseling. And so this is a line that if a patient wants to call up and just say, I was triggered by something that happened, I really am having really, really strong cravings, I think I'm going to use, but they could call and someone could be there with them to make sure that they don't have a overdose, especially a fatal overdose. Next slide. All right, emerging practice. I would be remiss if I didn't acknowledge that a lot of exciting work is happening around opioid use disorder treatment in emergency department settings. Many of you might be in states that have sort of these so-called bridge programs that are being developed out of emergency rooms. So California, we've had a bridge program running for many, many years. I just grabbed a screenshot there. They have developed lots and lots of protocols for starting medications for opioid use disorder when someone is in the emergency room. Next slide. The other exciting thing that's sort of happening around this space is that I've heard that some states are looking at whether emergency response personnel may also be able to sort of jump in and be part of this care cascade, if you will. So, first responders in the field that may be responding to an overdose, there is some movement to see if they can help sort of, shift up the timing around having conversations with buprenorphine with patients in the field. Next slide. All right, so let me move on to medication initiation. Next slide. So this is a different call that we received, and this time it was actually from a provider who was seeing patients in a jail or a correctional setting. We know that HIV is disproportionately, or rather people who are in correctional settings are disproportionately impacted not only by HIV, but also hepatitis and also substance use. And jails are, have their sort of own unique set of considerations, but can be really well positioned to talk with patients about starting medications for substance use disorders. So as you can see on the slide there, this was a 36-year-old cis female, had a history of cocaine use, but had more recently started using heroin. As it turns out, she had tried or had been interested in the IM naltrexone for opioid use disorder in the past, but really wasn't able to start it. And I think this is not an uncommon scenario. With naltrexone, in order to sort of successfully induce onto the naltrexone, patients have to abstain from opioids for a sufficient period of time so that they don't go into withdrawal with the first injection. So this jail provider astutely sort of got the sense that the patient was very motivated to be treated, but just needed maybe to sort of have another conversation about what their medication options may be. And the patient at this time was really open to buprenorphine and wanted to hear more about it. But, she just had some concerns. I think she felt a little bit poorly about what happened with the IM naltrexone, and I think was just looking for some support and information to, know that she could continue the buprenorphine if they were to start it during the incarceration. And so as it turns out, this provider opted to start the buprenorphine induction with a 2 milligram dose, did really well. And then the question comes up around, okay, well, what happens after you are released? The patient really felt like if there was a long-acting medication available to her, potentially that would really help her not return to use, because there were just sort of daily challenges that she just felt a little bit uncertain about being able to, take the buprenorphine tablets or films on her own. So the call to us was, okay, how can I transition this person from the transmucosal or sublingual formulation of bup onto the long-acting injectable? And I have to say, we get lots and lots of calls on our substance use warm line about transitions between different medications for OUD. And so this, I think, is a really important topic to be aware of. The guidelines are the guidelines, but clinical practice and what happens in the real world does not always follow the guidelines, right? And so go ahead and actually go to the next slide, please. So we just sort of talked with this provider about, okay, if you look at the package insert for the long-acting injectable, it will say that you really want to have someone stabilized on sublingual for about a week. We have heard that there are some programs, sometimes in correctional settings, sometimes street-based programs that are trying to sort of compress the time to the first injection of long-acting. And I get theoretically why there's sort of an attractiveness to this. But again, this is an area that we don't have a ton of evidence. And so we're really looking to understand what is the best real-world practice around this transition. Next slide. As I mentioned before, we are really learning from those of our colleagues who are working in the correctional health space. This is actually a pilot that was published from, I believe it was Rikers. So the medical team at Rikers was able to sort of roll out long-acting buprenorphine for a number of the people they were caring for, and really had amazing outcomes. And I think they did a great job also linking patients to outpatient provider after release. Next slide. So, when we got the call, we just said ideally, patients tend to do best if they have been stabilized for at least several days. But certainly if there is an appeal for the patient to get the long acting at some point, again, getting back to that linkage of care, if that's the plan, you want to make sure that we can sort of support that actually happening. Next slide. Great. Okay, I'm going to start wrapping up. Next slide. In terms of sort of supporting someone as they go through their journey of recovery, this is also a question that we get quite commonly on the line. So this was a call from an outpatient provider who had known this person for quite some time. They had been able to start buprenorphine and were doing really, really well, had some positive changes, regained employment. They were able to reconnect with family members. It just seemed to be going in a very, very good direction. But then, as sometimes happens, sort of per the practice protocol, the provider was ordering regular urine tox screens, and lo and behold, there were just some test results the provider really didn't know quite how to interpret. And ultimately, the question is, this person, seems to be doing well. They're on treatment for their opioid use disorder, but now how do I reconcile that with what I see in the tox screen? And I'm just afraid that maybe the patient is, not sharing all the information with me that maybe I'd like to know. So I won't walk too much through this, but basically we know that this is a really common question that happens in practice. And I think from our standpoint, it's always important to step back and acknowledge that a urine tox screen is one point of data. And for this particular case, there is a lot of other information to be able to include, and that should be included in your assessment to be able to make a plan about, okay, BEEP seems to be working, but there might be something else going on. This is an opportunity for us to talk about that. Next slide. And so, some of these questions around patient monitoring came up with the pandemic. And so some of the professional organizations have released some guidances around best practices. This is just a snapshot of one of the ASAM white papers that came out. Next slide. Next slide. I put the link down there for folks who are interested in reading a little bit more. Next slide. And then for this particular case, it did seem to be the case that potentially the person was adulterating the urine just because of the way that the levels are being reported as far as the concentrations. And so, we wanted to, the caller really wanted to preserve, this therapeutic relationship with the patient, and the patient was very, very motivated to stay in care. So we just tried to provide some support to the provider on how to start having those conversations with this patient. Next slide. All right, so some of you might remember that the CDC came out with this opioid prescribing guidelines a number of years ago, and sort of got a lot of feedback around this. Just if folks were not aware, a couple months ago, they were sort of open for public comment to come out with the next version. So for those of you who are interested in providing some comments around how the new guidelines can be updated, I invite you all to do that, and hopefully the link might still be active. Next slide. These are just screenshots from some of the draft recommendations. So again, I have the link there, and hopefully it might still be up for public comment. Next slide. All right. The other thing is, I know that I spend a lot of time talking about cases involving people with opioid use disorder, but that is not all that we can help with. We do get a lot of calls around other substances, alcohol, stimulants, and also some emerging substances. So we just welcome calls about any substance use related question. Next slide. All right, here's our number. And then I think there's also a slide with our other warm line numbers for our HIV related lines and our Hep C line. I am happy to share my email, but our program director email is there as well, Brenda Goldhammer. Anyone with programmatic inquiries is welcome to reach out, but certainly if you have a clinical question about a patient, please call any of our numbers, and we are totally free. Next slide. Is that it? Oh, sorry, you can move on. I think there's a slide that has the numbers, if you can show that. Can we move on to the next slide? Did it get taken out, maybe?
That seems to be it.
Okay, sorry. All right, let me, the URL that I put in the chat has, if you go to that, it will show all of our numbers. Apologies for leaving the slide up.
Well, thank you both for very informative, information-packed presentation. I mean, it's amazing. I mean, all of the considerations that obviously were put together in developing those toolkits and then developing the consultation lines, that there is recognizing all of the systems considerations and what has to be in place before we can offer services, who has to be involved, and how do we make this as patient-friendly as possible. And then once we are providing care, to know that we do have these clinical consultation lines that can support us in the provision of it. So it really shows the comprehensive range of what the AETCs can provide. And I also think what a great link also with the regional AETCs, particularly as we're engaging in practice transformation and helping each clinic transform their practice in whatever they want, that we have these tools that we can help bring to you as well as you transform your practices. Have we had any questions, Liz? And if you have any comments or questions, please continue to write in.
There are currently no questions in the Q&A pod or the chat, but we do welcome questions at this time.
And John and Carolyn, are there ways of, once we access those tools and go to those links, can people provide feedback as well to the tools, or?
Yeah, on the NCRC website, for each resource in our library, there is a feedback on the right-hand side, I think. We look at those on a regular basis. So please, any feedback would be great. Or you can also email me, and I'll put my email message if you have difficulty finding any resources, or if there's another type of resource you're looking for, feel free to send me an email.
I highly recommend folks visit the websites for the NCCC and the NCRC to visit not only the resources that were presented today, but the other clinical consultation tool lines, as well as the other tools that are available on the NCRC website. There's John's professional email.
I must say, just as from the clinician perspective, the warm lines are incredible, because as Carolyn was saying, you can't predict every next person that comes through the clinic door. And there's some people with some certain medications, certain disorders that are not that common. And you want to make sure that adding antiretroviral meds or buprenorphine or any other is safe. And they, besides their physicians and nurse practitioners, they have an incredible network of pharmacists as well. So it's great. And they say, yeah, you don't need to worry about that. Those are all okay. Or, yeah, I wouldn't use, TDF, I'd use TAF, or whatever the scenario may be. So they're a great resource if you haven't ever used them.
Oh, thank you, John. That means a lot. I mean, and I think the other thing, just to acknowledge, so it looks like we might have time, is that we know that a lot of healthcare workers are being deployed, right, outside of, away from their usual positions. And so there's a huge strain that has, occurred in terms of healthcare personnel. And so certainly we would love and be honored to help play a supporting role if your local specialist just isn't as available as perhaps they may have been. We are not a substitute for having that sort of face-to-face interaction with the patient, and that's not the role we play. But certainly, if you've got a clinical question, just in case that you really want to have another set of eyes and ears on, we would be happy to serve.
And it looks like we had someone who's having difficulty accessing the links on the resources. I think if you email directly to John, maybe you could send out the resource directly to that individual as well.
Absolutely. I was just typing in there that obviously you'd have to click it on the computer, not on the printout form. But if it's not, these were just recently added, so they should be clicking and linking to there. But I have a list of all the links, so I could provide that with you if you want to send me an email. But thank you for letting me know, and I will check it right after this to make sure it's working, because there's some great resources on the back there.
Thanks, John. Well, thank you both again for presenting. I see we're at the top of the hour. So thank you again. And for those who are requesting continuing education credits, there is a link in the chat for the survey. So please do that to get your credits. And thank you again. Have a great weekend, everybody. Take care.